before Professor Moritz starts, Professor Moritz will be the president of the EFP in 2024. Professor Moritz, the screen is yours.
Many thanks, Nadim, for the kind introduction, and many thanks for CAP for organizing the event, and for NSK for supporting the event. I can only use my very rudimentary Japanese to say arigato gozaimasu for that. I will present the new treatment guidelines that were produced by the European Federation of Periodontology, and I was quite involved on state-of-the-art perio treatment today in 2021. So the big question in everything in dentistry, and specifically in perio today, is if you have a patient with a pocket like this, if you have a patient coming in with periodontal disease, what am I going to do? Who or what tells me what works best? Well, that was traditionally something that you would have done at university, at your alma mater. So you said, back at university 20 years ago, I learned the following from a big professor, and I've done it ever since. We maybe also learned something at CPD courses, maybe at CPD courses like the ones that you can see from CAP, and maybe, and that's something that most of us do, and I have done this when I'm in clinic too, we will use that information to distill our own way of doing periodontal treatment. This is something we call clinical experience. The big problem here in clinical experience is that it's quite nice, it's stuff that works in our hands, but it also has the problem that we are just a single observer, so we cannot really be sure that it's really the best method. This is why there's a lot of emphasis in many areas of medicine, and specifically in perio and implant dentistry, on studies, on scientific works that will compare one method against the other to tell us what works best, on studies over a long period of time in many, many patients that a lot of us couldn't even do in our time. Now the problem here is that often studies are a little bit artificial. They're like from a laboratory environment, from hand-selected patients, and there are a lot of them. So I can tell you as a professor, even I cannot read all of them in my given time. So we have two things. We have clinical experience that has benefits but also shortcomings, and we have papers, we have scientific literature. And how can we make the best out of both worlds? This is where guideline development comes in. Guidelines have been developed for a long time. The first ones, and apologies if my hat is in front of the very big slide here. The first ones were S1 guidelines, where you sit down with a panel of experts that could be your friends, all from the same environment, and do an informal procedure to reach consensus. So you would sit down, informal procedure. In many ways, it involves several bottles of wine. You sit down with your friends and you decide on something. The problem is, after a couple of bottles of wines, it's only those that are still standing that can make the recommendations, and it's maybe not very scientific. This is why there were better, more high-quality guideline developments developed. One that is based on evidence, that is based on a systematic review of all the literature there is, and one that is based on consensus-based information from a representative guideline group. So it means I cannot only invite my friends that I want to to invite for a bottle of wine, but I would also need to invite everybody else who is involved. In perio, that could be a prosthodontist, an implant dentist, an endodontist, a dental hygienist, a dental student, a patient. It could also be a maxillofacial surgeon that has to repair stuff afterwards. So we would have a very broad selection. Now the big problem here is that the evidence-based, yes?
Excuse me, Moritz. Can you just come closer to the microphone? Some of the participants are complaining about the voice.
Okay, sorry for that. Is it better?
Okay, that's better.
We never had any problems with that. Okay. So,
okay, thank you.
Thanks a lot for you. Okay. So in summary, there are two ways: evidence-based and consensus-based guidelines, and neither of them is the full big story, because we're lacking something really here. So this is where the highest quality guideline that there's available came in, which is both evidence and consensus based. So it summarizes a systematic review or several systematic reviews where all the literature is taken on board, is selected and synthesized and graded. That means quality assured, with the representative guideline group and a so-called structured, moderated consensus conference. So this is what we have done in the European Federation of Periodontology, and you see European is not only the core European countries, but it also includes European countries such as Argentina and Australia, so it's really world-reaching, and it's the biggest learned society for perio worldwide, and it's the organization that actually has the manpower and the means to undertake such a big project. I had the pleasure to be amongst all these famous periodontists here, the young fat guy in the background, to be co-leading on this effort. And we were supervised by a very, very strict moderator, that's Ine Kopp from Germany, who's a very strict person who told us all to behave and to follow the methodology really, really well. The whole process was based on 15 systematic reviews, so it's like a big textbook, so it's like many hundred pages of information, and all the information from these systematic reviews were distilled by a representative guideline group of about 100 people, many famous people from different disciplines there, including proth, including endo, including implants, including dental hygiene, including students. So we had a real background of those that need to work in perio, that need to work with this, and we produced this paper that came out in the Journal of Clinical Periodontology, and you can read it online free of charge. It's a quite lengthy paper that gave us information and included 62, that's quite a lot, 62 different clinical key recommendations, some of which I will highlight this afternoon. Just to make sure that you understand where this is all coming from. It's a very intricate process, and I don't want to bore you with all the academic stuff there, but it's important to understand that it's not only a combination of quality of the evidence, quality of the papers, and the strength of recommendation. This would be classical. So you have fantastic evidence, you get a strong recommendation. I made this very green and very red. It's either we recommend, that really means do this, or recommend not to, that means you should not do this absolutely. If you have less good evidence, it's moderate evidence that would just get a less strong recommendation, like I suggest not to do something, or low evidence that would end up in an open recommendation. Yeah, we don't really know, but you may consider doing the following. Maybe it works, but it's less strong than the other ones. But the problem here is that if you just go from evidence to recommendation, you're missing a lot, because as you know, a lot of these studies, a lot of these papers are a little bit funny at times. So there are a lot of factors here, like the relevance of the outcome, the consistency, and importantly, the applicability of the evidence to the target population. Does this work in my patients, and is it really worth it? Is there good benefit of benefit-harm balance? This is something where the clinical expertise, the combined clinical expertise of the guideline group comes in. So we had these 100 people that looked at all the clinical information from the papers and said, well, does it really work? And I will point out several areas where the published evidence deviates from the final recommendation. In one point, we basically did a 180 degrees. So we went from a very strong recommendation based on papers to a very strong negative recommendation based on the clinical expertise. Said, even though the papers say do this, we want the opposite. It's about systemic antibiotics. We'll come to that in a second. And indeed, a lot of it is about upgrading and downgrading evidence and really questioning, is this a clinically relevant effect? You may have people coming into your practice saying, well, use our new stuff, use our new drug, use our new gel, it's statistically significant, but it needs to be clinically relevant rather than only statistically significant, just to make a difference for you. And this is what the guideline group did for you. So you have 62 different recommendations, and they come in a specific, a little bit boring format that first of all gives the supporting high quality systematic review, and tells you what the background of it is. It tells you what kind of recommendation strength you have. Here we have the recommend, that's like 2 arrows up, and it's the strongest recommendation we can give. And it tells us how many of the about 100 people supported it, if there was a strong consensus or whether there was a unanimous consensus that everybody in the room said this is fantastic, I want it, or whether there was just a simple majority. And this makes a big difference in the confidence in the whole thing. One of the problems here could be that this is for the entire world, and depending on where each of you live, there may be a local version of it, because often recommendations do not work as well in every single healthcare system in the world. And therefore we have started a process where the national societies are asked to adapt or take over the recommendations for the environment. Typically this is being done either by a translation with a commentary, which is a little bit weak, but it's like the minimal thing, and you may have seen that in many different countries, in Turkey, etc., they do a translation. You can also adopt it. You can just say, well, we can take this and say, this is what we want in our country, and we give it to our Ministry of Health, we give it to all the insurance companies and say, that's what we want. What's the problem with adoption? The problem with adoption is typically that you get something where you cannot pick what you're getting. So it's very difficult. So you have to take the entire package. This is why the EFP has recommended, and you will see that in many countries, a process that is called adolopment, which is a new word, adoption, adaptation, and development of new guidelines. That is supposed to not reinvent the wheel, but to take a high quality guideline that we already have, that's here, that's from the EFP, and to modify it in a way that it works for your local society by adopting it. That means taking over, modifying, or even making new recommendations. And this is something we have done over the last year, for example, here in Britain, also using Zoom. I've been personally involved as the last author in the British version and as first author in the German version. There's also a Spanish version that has now come through. Please make sure, because I've seen in the background that some people had problems seeing me. If you have difficulties to see me, you can hover your mouse over the picture of my screen and click on the 3 dots and say pin. And the pinning will make sure that I'm always in the foreground. It can also blow me up to full screen. You can see both me and my slides. So right hand side, 3 dots, pin, that's the 4th from above, and you will be able to see me. In addition, I think NSK will have a recording of this webinar on their websites. At least that's what I heard. So you will be able to get me in very good quality afterwards if you want to see some stuff. Yeah,
Prof Morris, just to add to that, we have some delegates also on mobiles. If you're on the mobile version, you can just slide to the right or hold your finger on top of the video, and you can also pin. So then you should be able to see. Thank you.
Okay, thanks for that. All these technicalities, but I'm very fond to have myself in the thing and to be able to point to stuff on the screen. So importantly, there are local versions, and there will be more forthcoming because there's central funding from the European Federation of Periodontology for the different local versions. So if you're in a country that doesn't have a local version, just ask your Perio Society, say, where is our development of the guideline, and they will either tell you where it is, or they will say we'll just do a translation, or maybe you can find yourself another one. The British one is very, very nice, to be fair. It is in the Journal of Dentistry. So what's in this guideline? What am I all talking about? The guideline is summarizing in 62 clinical recommendations how to do perio treatment today. Importantly, it's a guideline. It's not the law. So we will not be shot or fined if you don't follow it, but it's the current recommendation how to best do perio treatment. And it's a stepwise model, like a ladder, like the stairs in your house. First of all, you need to climb the first step. That's the basis of therapy, where you do an exam, you assess risk factors for perio, and you do a diagnosis. And typically we will follow the new EFP-AAP classification. And if you have done this diagnosis, you have found that there is periodontitis, you would initiate periotherapy and climbed the next step in the ladder, which is the first step, the control of local and systemic risk factors. And that's very new because we are actually addressing systemic risk factors right away in the very beginning of periotherapy, sometimes even before thinking about oral hygiene and all these things. And we combine that with something we call professional mechanical plaque removal, or PMPR, which is a new word. Attention, new word here. And this new word is a scale and polish. It's a superficial cleaning that has a medical background rather than a cosmetic background. And there's actually some evidence for that. The benefit is that in a lot of places the tax authorities starting to tax cosmetic procedures, but they will not tax medical procedures. So this is the appropriate medically indicated superficial cleaning that we will do in step 1. If there is still a pocket left after step 1 therapy, we would initiate the second step of therapy, but only in those patients that actively work with us. If you have somebody who's not doing anything, you may want to repeat parts of this until you have adherence or compliance. Adherence is the new word. Then in step 2, we would do what we used to call scaling and root planing, root surface debridement, subscaling. The new word is subgingival instrumentation. That is the instrumentation of the roots in some cases, but very seldomly so, with adjunctive measures that I will go into later. And ideally, this would lead to resolution of disease, and you can just go to a supportive therapy. In many cases, it does not work, and you still have residual pockets, and you would need to go to a phase of periodontal surgery. And I've seen that we have a couple of people on the panel that are very knowledgeable in this area, so I'm looking forward to a nice discussion afterwards. And hopefully we would be able to reach an endpoint with only shallow pockets, that is, pockets including 4 millimeters of depth and no bleeding and probing, before going to permanent supportive periodontal therapy. That is, because the perio-patient never ceases to be a perio-patient, a permanent measure. So you have 4 steps and the basis of therapy that you have to climb one after the other to treat all gum disease patients. So let's go through in detail and to give you a couple of background information what all these steps entail. First of all, you have the basis of therapy, and this is predominantly the diagnosis of perio. And there is a new classification that was involved. I had the pleasure to be there in November of 2017 in Chicago, Illinois, in the United States, where about 120 people from all over the world decided to no longer distinguish aggressive and chronic periodontitis, but only to have one kind of periodontitis that is now further categorized like a tumor based on staging, that is severity and extent, stage 1, 2, 3, and 4, or the progression rate, and that is grading. So you would end up with different stages and different grades of disease. So a patient with very severe disease could be a stage 3, a generalized stage 3 patient, and if there's a lot of disease progression, you would end up with a grade C. And I think you all have seen this. This has been around for a couple of years. The important information here is that the stages of periodontitis, and this is only those perio cases that are defined by pockets, bifurcations, by deep interosseous lesions, and not necessarily by the need for interdisciplinary restorative treatment, would directly map to the different steps of therapy that you need to do. For example, the very mild stage 1 or 2 perio cases will possibly never need corrective surgery, but everybody needs the first step of therapy with local and systemic risk factor control, and everybody needs SPT always and forever. Once they have perio, there's no way you can get around it. So imagine you have done your classification according to the EFP classification scheme that has come out 3 years ago, and you have diagnosed periodontitis. So what are we going to do next? We will initiate the first step of therapy, and this is importantly the control of local and systemic risk factors. What are risk factors? Risk factors are factors that cause periodontitis, and we now know that there's some truth about genetic risk factors, but we cannot really modify them. But there is a strong role of systemic risk factors such as diabetes and modifiable environmental factors such as smoking. And there has been a strong recommendation, so 2 arrows up again, by the guideline group as at the start of everything, before we even look at the plaque in the mouth and even before we look at scaling or whatever, to control risk factors. This is namely a strong recommendation to get diabetes controlled. I just had a patient yesterday that had a horrible diabetes control, and now she got a pump, the insulin pump fitted, and her diabetes has improved massively and her perio has improved massively too. So I have a fantastic treatment success in this patient, but it's possibly not my golden fingers, but it's I think it's the person that put the insulin pump in. Likewise, there's a strong recommendation, the best we could ever give, to get smoking cessation done, and typically this is not done by the dentists themselves, but by pushing those patients to health insurers, to general practitioners, to medics that are specialized in this. In addition, there has been some recommendation to improve the lifestyle of the patient, to get weight loss done, to get better food in, to have some more physical activity. And there are data supporting that this will help with resolution of inflammation, but they are not as good. And as you have seen, if the data are not as fantastic, you often end up with an open recommendation. This means you can consider getting your patient to improve her or his lifestyle. And I personally do this very strongly. And this is something that we do all over the place, even before thinking about biofilm mineralized deposits. I mean, this local risk factors you all know, so we need to make sure that all the bacteria and all the mineralized bacteria go away. In order to do so, we first of all need to make sure that plaque retentive restorations or devices are minimized, are reduced, all these overhangs are going away, and we would need to make sure that we have an active reduction of plaque retentive factors that make sure that the patient cannot brush properly and we cannot professionally clean it as well. And then we would need to work on the patient. And we would need to work on the patient to engage the perio patient in behavioral change for oral hygiene improvement. So we would want to switch the patient over to a better mindset that makes it easier to keep up the good work for a long period of time. Because as we have seen, a perio patient never ceases to be a perio patient, and we are in for the long run. And there are quite a few oral hygiene recommendations that I will just summarize because there are so many. Importantly, these are shared all over the place between step 1, the initial therapy, and step 4, the supportive therapy, because there is not a big difference between the fresh untreated perio patient and the maintenance patient in these recommendations. In summary, there was a strong recommendation to take into account the needs and preferences of the patient when choosing a toothbrush. This could involve a power toothbrush, but as you can see, it's again one of these open recommendations. The data are not as strong to say everybody needs one for sure. There are cases where I consider to do so. Yes, I recommend electric toothbrushes quite a lot, but it depends on the patient, his or her needs and preferences. Where we do have a very, very strong recommendation is on interdental brushes. So whenever you get an interdental brush into an interdental space, that's the method of choice. You should not use flossing as the method of first choice. It is actually the least choice. If you can get nothing else in, flossing is good. But everything else is pretty much better than flossing in the systematic reviews underlining these recommendations. And there is a little bit of critical thinking about antiseptics in dentifrices or toothpastes and mouthwash. This should only be done in specific cases. That means in cases where you have nothing else available to improve the maybe suboptimal individual home care of the patient. So if you say, well, I've done everything and it's still not good, then you can think about, okay, well, I might give him some antiseptics in the toothpaste or mouthwash, but not beforehand. So chemistry is not a replacement for mechanical cleaning. And then finally, when the patient has cleaned nicely at home and has learned how to do that, we will help the patient with some PMPR, professional mechanical plaque removal. That is predominantly the use of scalers. This can be manual scalers or powered scalers, and there's a huge range available. I personally, as you may have seen, I'm using this device here most of the time. This is a combination of a ultrasonic piezo scaler and a air polishing device to get rid of every single biofilm or mineralized deposit I can see or remove. This is often also done by my hygienists. And after doing so, after having controlled local and systemic risk factors, and after having done this medical, professional mechanical plaque removal, and there are still pockets left, and my patient is working with me, I see they are engaging, there's patient buy-in, I can proceed to step 2. If there's no buy-in, I would rather stay here. Step 2 is everything we have done in step 1 plus substantial instrumentation. That means we will debride the deep pockets using curettes, sonic or ultrasonic scales. Indeed, there is a strong recommendation to do so. So whenever you have a deepened pocket, the root surfaces should be instrumented. Instrumented does not mean like planed and does not mean destroyed, but it means cleaned from hard and soft deposits. What to use for these is a little bit depending on your choice. So there are no massive differences in very large clinical studies that would warrant different recommendations. It depends a little bit on what you like to use, and it depends on the area you're working. I personally use a piezo device, as I've shown you before. This is the NXK one. It's quite nice, and I use curettes, very sharp, strong curettes in certain areas where it's like a very big substantial calculus that I can just flip off. But you can also, for example, look into air scalers, sonic scalers. They have some advantages in theory because they have a very round way of working that is, depending on the person using it and the situation, eventually beneficial. But it's not as beneficial that it would have made a big difference in the guidelines. So all of these are safe to use and are very recommended. The mode of delivery, you may have heard about full mouth scaling, FMS, full mouth scaling, do everything within 24 hours. It is was quite hip like 10-15 years ago, but we have seen that the actual benefit of it is relatively low. So there is no real use for full mouth scaling if you don't feel that you need to do it for a certain reason. I often do quadrant-wise or side-wise scaling, and it's a little bit soft on the patient, especially on the multimorbid patient that can have a lot of systemic pressure, a lot of inflammation from the full mouth scaling mode. And these measures can, in theory, be combined with adjuncts. Importantly, the guideline has very strongly made clear that adjuncts are apparently not as important as we would have thought. So the step 2 periotherapy, the key of the periotherapy, comes down to your ultrasonic scaler. That's the most important part, what you or your hygienist do in your practice with your instruments. That's important. The adjuncts are not as well working or not as easy to use and not as efficacious as we would have thought. There's quite a list of things that are negatively recommended, so that where the guideline says you should use it. And this includes lasers, adjunctive lasers, or adjunctive photodynamic therapy, antimicrobial, that did not show any effect that was considered high enough by the guideline group to be relevant and to be recommended. And we have negative recommendations for probiotics, which I found interesting because they have been pretty hip in the last years, but the data are just so heterogeneous that we couldn't really recommend them with a good feeling in our hearts. There are a couple of things that do have at least open recommendations. That means no thumbs down. So in certain areas, you may use chlorhexidine rinses, especially in those cases where you have temporarily limited ability to control plaque. That's the good working patient that has broke his or her arm during your active therapy. So if you have somebody who says, oh, I cannot brush any longer because my arm broke, or whatever, my water is not working, then you can say, well, then you take this bottle of chlorhexidine and rinse with it. But the effect is not very strong, so it's only an open recommendation. One of the problems with all these rinses is that they have difficulty to get into the pocket. If you want them to work in the pocket, we have an open recommendation for chlorhexidine chips, which is a sustained release device for chlorhexidine that you can put into the pocket. That seems to work, and this is the Perio chip product from Kebschull in Israel. And there are also open recommendations for adjunctive local antibiotics, where you have products like doxycycline with sustained release in the pocket. One problem with all the antibiotics, and the guideline group was very strict on that, is that with all antibiotics you have to be concerned about the overall use of antibiotics in the individual patient in public health because of all the resistance buildup. So we should be careful with antibiotics. And this antibiotic carefulness has been extremely strong in the question of systemic antibiotics that we tend to use. And this is one of the big examples. You remember where we had this evidence to decision framework, where we had fantastic data, and there's a lot of fantastic data on amoxicillin, metronidazole out there. However, even though there's a lot of efficacy data, we have given the whole thing a strongly negative recommendation. Said, even though this seems to work, we should not at all, do not, so it's 2 thumbs down, use this as a routine therapy for everyday practice. So it's not that you give that to every patient. You may, and this is an open recommendation, consider to do so in certain cases. For example, young adults with severe and rapidly progressing perio. If you have a 25-year-old person that has lost 1 centimeter of bone on all teeth, with no smoking, fantastic oral hygiene, no other risk factors, yes, in this case I would consider to give amoxicillin metronidazole as the first choice, but not in the 60-year-old that's smoking like a chimney and never brushing. So there are a lot of other things that I could address there first. So this is a big difference. The data say it's fantastic. We say, well, it may very well be so, but it's not a good idea in the overall picture to do so. So we are going away from antibiotics. In summary, this is step 2, and step 2 gave us the information that subgingival instrumentation with all the devices I've shown you is key. Everything else is an addendum, and most of them only have open recommendations. That means you may consider doing so, but it's not something that should be the center of your work. So the center is here, and this is all fine print. And don't forget, antibiotics are no routine therapy. Now you may be in the situation that you have no residual pockets deeper than 4 millimeters here, and you could just go directly to supportive periodontal therapy. This is, however, not always the case. So we have the case where we may need to get into perio surgery and need to do additional things. Depending on how often you do that kind of stuff, it may not be something that you will do every day in your practice, but it's important to know what stuff is available and what you can ask for. So what's the problem if I have a deep pocket after periotherapy? Indeed, we know, and this has been informing the guideline quite a lot, that probing depth after therapy is predictive for tooth loss over time, even with fantastic maintenance. So this is from Switzerland with fantastic dental hygienists, and you have an almost 10-fold increased risk for future tooth loss if you leave a deep pocket after therapy, because your dental hygienist will not make sure that the tooth is retained. So if we have a deep pocket, it needs to be treated. However, it needs to be treated under certain caveats. So you can only go further with periosurgery if you have a patient that is cooperating with you, that is working with you actively, and when you have training in surgical techniques, some specific training. And I'm giving all this training all the time, but it's important that you have learned how to do that. And especially in those where the patient is not cooperating, and or you don't feel sufficiently trained to do it, consider alternatives that could be using your piezo ultrasonic device that I've shown you at every time you see the patient to rescale or re-instrument the residual pockets. That is something that is specifically mentioned in the guideline as an acceptable alternative if you cannot make sure that you do something additional on the patient. If you have all of this stuff in place, you would want to see why you have the residual pocket. And most often it's that you haven't removed the biofilm completely because it's difficult in some pockets. And depending on how deep it is, you would either take your sonic, ultrasonic scale and just rescale the pocket, repeat subgingival instrumentation in shallow pockets, or you could go in and start a surgical procedure, so a surgical approach with an access flap, often preserving the interdental tissues. So just open up, let some air in, take your powered instrument, take your piezo and clean the root surfaces and close it down again, that you wouldn't even see that something has happened in this area after a week. This is not really possible in areas where we have intraosseous defects, we have bony defects, because those bony defects need to be resolved, and they can be either deep or quite often, especially in the posterior, quite shallow. And these shallow pockets have a recommendation to be treated with resective surgery. That is a thinning out of the flap, surgical thinning out. So this is like a 5-6 millimeter thick platal tissue that has been thinned out with a 15C blade to be like 2 millimeters. In addition, with the recontouring of the bone and osteoplasty and osteotomy using devices. I personally use a implant motor, an SK implant motor with a red fast handpiece, electric handpiece on it to recontour the bone. You can also go in certain cases and use a piezo surgery. That is very, very nice because it's very minimally invasive. And there's one study out there that actually shows some healing advantages of this approach versus that approach with the high speed. Importantly, make sure that you have irrigation with sterile saline when you're working on the bone. And this is something that has a recommendation, but you can see it's only one thumb up. The background is that it comes with a couple of downsides. You will get more recession with these approaches, so you should predominantly do it in areas where recessions are not a big problem. The nice thing is that this type of surgery is very, very predictable and very satisfying for both the patient and the practitioner. You occasionally also run into very deep intraosseous pockets like the one we had here with 12 millimeters of intraosseous defect depth. You cannot just drill this away even though you have a very nice NSK motor for that. You should, in these cases, go in and fill this up and regenerate the bone. Typically this is done with a membrane or emdogain, possibly in combination with a filler of bony origin. This can be autologous bone or products like BioOs, where you have bone that is denatured in a certain way to leave only the bone mineral, but it should be bone and not ceramics and nothing artificial in order to work. And then you can have defects like these. This is 14 millimeters of probing depth. This is 12 millimeters of defect depth, and I filled it up with a mixture of emdogain and BioOs, and I went from 14 millimeters to 2.5-3 millimeters of probing depth, and we can see a pretty much complete fill up of the defect with this stuff. So you can, those of you that do that kind of work, you see there's some BioOs in here that gives you a little bit more density in the radiograph. Importantly, when doing so, please make sure that you can only do this in patients with favorable subject factors and favorable local factors. That is, a patient that is really working with you. So if it's not clean and nice, I wouldn't even touch this, to be fair. Lastly, there is a big issue in perio with furcation involvement that still is one of the biggest troubles we have. And depending on the area, there are quite a few recommendations and quite a few options that you can take. And the evidence is relatively low here. This could be including non-surgical, and you can see that's the glycine powder air polishing that I quite like to use. Regenerative measures where we grow back bone. Resective measures where we resect parts of the tooth and make it a premolar, or we remove parts of the tooth. And as far as I understand, we have a real expert on this topic in our panel for discussion in a couple of minutes. And some people actually try to pull out teeth and extract and place an implant. Importantly, the guideline has been very strict on this, and they said, well, just by having furcation involvement, it's not a reason to extract it and place an implant. You should try therapy first. So first of all, furcation grade 2 or 3 should receive perio treatment. This could be regeneration in mandibular, lower, furcation grade 2, or in maxillary, buccal, furcation grade 2 in the upper, like upper 6s buccally with regeneration. In all the other cases, it's pretty much everything you consider appropriate at this time, including non-surgical therapy, open flap debridement, attempt at regeneration, or resective surgery. So we do stuff like this, a very difficult case with a horrible prep with all furcation grade 3, where I have raised a thinned out apically repositioned flap, and I've sectioned the teeth according to my pre-made plan based on a cone beam. Importantly, again, this can be done using a machine that has cooling with sterile saline, and I don't use the implant burr that you can see here, but I use a high-speed red banded electrical handpiece that is fantastic for this use and very safe around the bone. I've removed a couple of these roots and then generated a prosthetic that incorporates these roots as single abutments, so you can have a full mouth case based on roots only. And this does work quite well if you do proper prosthodontics, proper perio, and a proper endo. And in the end of the day, you would hopefully reach the end point of no probing depth deeper than 4 millimeters with being probing, and reach the step 4 supportive periodontal therapy. This should be done within every 3 to about 12 months. Most of my patients are either 3, 4, 5, or 6 months, so that's the range. 12 months would be very, very extraordinary. I personally make sure that at least half of the typical SPT session, that's an hour with me or my hygienist, is focused on things like exam and diagnosis and risk factors. So it's not only about cleaning, it's about talking to patients, finding out what their problems are, motivating the patient again, doing oral hygiene instructions again and again in a repeated and targeted way. And so the cleaning is just a very small part. We do know that we can, by going into risk factors again and again, we can make sure that disease recurrence is minimized over time. So there's an integral part of SPT in the control of systemic risk factors. So if you have a smoker, you just don't tell them about smoking cessation once when you start treatment, but again and again and again and again and again. So whenever you say, well, you should use this type of interdental brush, you can say, and you need to go to your doctor. And I saw him on the street and I said, well, you need to stop smoking because it's horrible. So importantly, stay on top of the risk factors. See, the behavioral change needs to be there by repeating it again and again. This does need time. We have already gone over the oral hygiene recommendations. So again, it's predominantly interdental brushes, eventually a power toothbrush, and flossing is not the first choice to make a difference. And it's the same as in the first phase of therapy. And we have a very strong role of professional mechanical plaque removal. Again, the key part of PMPR traditionally is always mechanical debridement, and especially in SPT, this typically means either a sonic scaler or an ultrasonic scaler. You may consider air polishing. The problem is that there's little data on air polishing, so it's not mentioned at all in the guideline. I personally use air polishing with glycine powder because it's the most researched one subgingivally, and I think it's important to make sure that you don't use air polishing with a carbonate powder because it's not suitable for pockets. And if you choose to do so, glycine powder is the stuff to go. It's very nice to have a device that has both. There are some information about other methods that are actually not recommended. Lasers and PDT are also not recommended, like in step 2 for step 4, the supportive periodontal therapy. And all in, this should lead to an improved quality of perio treatment, because it sequences your treatment so easily. In summary, we do have a guideline that's the first international high-quality guideline periotherapy that combines the clinical experience of a large guideline group. So it's not only a single person, it's not 10 people, it's 100 people from different disciplines from all over the world, with the systematic evidence appraisal. This is 15 different systematic reviews, and we all had to read them until we felt very sick, and we all had to make sense out of them. So it's the clinical common sense when reading these papers. Importantly, the S3 guideline is based on the new classification scheme, as are the different implementations, and it allows using 4 simple steps to basically treat all levels of case complexity. One thing that is still missing, but that you will see in this year or the next one, I think it's going to be in spring 2022, is how to treat the interdisciplinary restorative problems in perio, the stage 4 periodontitis patients, where you also need to do a vertical blight increase, where you may need to place implants, where you need to do big prosthodontics, but that's a totally different thing. So it's not actual perio, it's perio proth or perio restorative, and there will be a separate guideline. I'm happy to speak about that in the future for that stuff, but it's distinct from the perio problems we have here. So at this point, and I think I have only spoken for 45 minutes, it's fantastic. I'm happy to be at the end of my talk, and I'm happy to have a nice discussion about all these things. So again, if you feel that this has been a little bit too much, you will be able to get the recording on the website, and you will possibly get a link to the PDF of the guideline document that has in Word document 160 pages. So it's a little bit difficult to digest. It was a pleasure to speak for you. And again, arigato gozaimasu to NSK Middle East.
Thank you very much, Professor Morris.